Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Health and Heart Disparities. If you have a question about anything being discussed today, please call or email at the end of our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You'll need to register for this program in order to access those materials. 2.5 continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in and evaluation sheet, as well as take a post-test. While content may continue to be relevant, the continuing education credit will only be awarded for 1 year for nurses, expiring on February 28, 2019, and 2 years for social workers, expiring on February 28, 2020. And now, let's meet our first presenter today. Dr. Reagan W. Durant is the Associate Professor of Medicine, Medical Director at Cooper Green Mercy Health Services Division of Preventative Medicine at the University of Alabama at Birmingham.
Hi, my name is Reagan Durant, and I have received research funding from Amgen and Amarin. Otherwise, I have no disclosures. The learning objectives for today include the following: to define hypertension based on systolic or diastolic blood pressure readings, to learn the prevalence of hypertension and the risk of end-organ complications associated with hypertension with a focus on health disparities, to learn the risk factors for developing hypertension, and lastly, to become familiar with the clinical evaluation and non-pharmacologic recommendations for the hypertensive patient. Let's begin. First, I'd like to start off with definition of hypertension. There really has been some evolution in the definition of hypertension. This is a cover sheet from the JNC8 publication that came out in 2014. For those who may be familiar with this process, the NIH and certain professional organizations such as the American Heart Association had begun the pattern of producing recurring guidelines related to hypertension. And this guideline was about 10 years in the making, and in that time period, the NIH decided that they no longer wanted to be part of it, so this was one that was put out solely by the American Heart Association and the American College of Cardiology. As a result, they came up with this definition, namely that diastolic blood pressure greater than 90 millimeters of mercury was considered to represent high blood pressure, or a systolic blood pressure greater than 140 millimeters of mercury was thought to represent high blood pressure. And this applied only to those less than 60 years old. And so it begged this question, so what represents hypertension in the elderly? And what they found is that in those 60 years or older, they thought that systolic blood pressure of 150 should be the threshold for a diagnosis of hypertension. The diastolic threshold was the same at 90 millimeters of mercury, but they had this higher threshold of 150 for the systolic for persons 60 years or older. And the idea was that this was based on a number of studies that suggested that perhaps folks over the age of 60 could have a higher threshold without having some of the same risk of complications of high blood pressure. However, that's not where the story ended with this guideline. Following the publication of the actual guideline later on that year, there actually was the sort of unprecedented event of a small group of people on the initial guideline committee presenting what essentially constituted a dissenting opinion, much in the same way that we may have a Supreme Court decision consisting of a majority opinion and a minority dissenting opinion. The same approach was taken here, and this group of committee members essentially said that we don't think that the higher threshold for those over the age of 60 is valid. In other words, we think the threshold should be the same regardless of age. And they thought that essentially the data supporting that higher threshold just was insufficient at that time to warrant using a more liberal threshold of 150 for persons over the age of 60. They also worried about the implications in that that higher threshold for those over the age of 60 might lead to some persons who still are inherently at higher risk, namely African Americans, persons with higher risk of cardiovascular disease like those with diabetes or chronic kidney disease, may be allowed to have a higher blood pressure that in the long run would not be good for them. So fast forward to 2017. That brings us to the current definition of hypertension. And this table depicts those categories of blood pressure in adults. On the leftmost column, you have the blood pressure category. And then in the center column, you have the systolic blood pressure threshold. And then in the rightmost column, the diastolic blood pressure threshold. For those who are categorized as normal, they have a systolic blood pressure less than 120 millimeters of mercury. For those, for the diastolic threshold, it's less than 80 millimeters of mercury. For elevated blood pressure, they have a systolic between 120 and 129, and those folks still can have the diastolic less than 80 millimeters of mercury. And then we get in the next rows to the actual folks who are considered to be hypertensive. In one group, we have stage 1 hypertensives, which are now considered to be hypertensive at a threshold of 130, extending to 139 millimeters of mercury. And for diastolic blood pressure, this begins at 80 millimeters of mercury and extends to an upper threshold of 89 millimeters of mercury. For stage 2, the threshold is greater than or equal to 140 millimeters of mercury, and then for diastolic greater than 90 millimeters of mercury. And as you can see here, and I have it below the slide, there are no exceptions for persons over the age of 60 years old. This was based on some more recent cohort data, as well as randomized controlled trials, as well as some meta-analyses which allowed statisticians to analyze smaller trials in aggregate and really see that some of the increased cardiovascular risk began at some of these lower ranges that now fall into the elevated and stage 1 categories. And because these elevated risk persisted across all ages, there really was no relaxed threshold for those over the age of 60, as there had been in the past set of guidelines. So let's talk a little bit about the prevalence of hypertension. This slide shows data from National Health and Nutrition Examination Survey. This is a periodic survey that is done in parallel with physical exams of roughly 5,000 folks. It's done on a recurring basis in the United States, and really gives us an idea about the snapshot of health and health factors across the United States. And what you can see in this slide is that hypertension increases with age. You can see in this graph, on the y-axis we have the prevalence of hypertension. On the x-axis we have different age groups, and each age group is stratified by gender, with blue bars representing men and red bars representing women. And so you can see that as you go from each stratum of age, you have an increasing prevalence of hypertension. And this is something we see for those of you who are engaged in clinical practice every day. More times than not, the older patients are going to have a higher likelihood of having high blood pressure. This is another slide using NHANES data. Similar to the last one, it shows on the y-axis the prevalence of hypertension. This time, on the x-axis, the groups are stratified by not only race, but also and ethnicity, but also the period of the NHANES exam. So we have three periods of NHANES exams, with the blue representing the earliest period, the red bars representing the next period, and then finally the green bars representing the most recent NHANES exam. And as you can see, in each group, within a group, the prevalence of hypertension is going up. But what I really want to draw your attention to here is that among African American, both men and women, the prevalence is higher than any other race sex group. So again, this demonstrates something that many of you may see anecdotally in your own practices or clinical care or in your own populations. We have a much higher prevalence of hypertension among African Americans compared to other racial and ethnic groups. So this slide explores the differences in prevalence of hypertension based on the two most recent definitions. As you may recall, a few slides back, I talked about the fact that there is now a lower threshold for diagnosing hypertension of 130/80, whereas the threshold used to be 140/90. And what this slide depicts is how the prevalence differs both across age strata as well as across racial and ethnic groups. So in the first row, you'll see that in general, with the lower threshold, the prevalence among adults is 46%, and this is based again on NHANES data, versus 32% with the old guideline. So again, not surprisingly, with the lower threshold, the prevalence has increased. When we look at age strata, going down the table, in the folks that are 20 to 44 years old, when we go from the 140/90 to 130/80 threshold, we see an increase in prevalence among men from 11% to 30%, and among women from 10% to 19%. So we see an almost doubling, both among men and women in this youngest age group. The prevalence is higher for the following age groups, but the difference is not as stark as we get to older age groups, particularly those greater than 75. When we look at differences with race and ethnicity, we can see for looking at African Americans and whites, African Americans with under the old threshold of 140/90 had a higher prevalence. Women, African American women had about a 16% higher prevalence than white women in that last column. And then in the second to the last column on the right, African American men had 42% prevalence versus 31% for white men. Moving again right to left, among women under the new threshold, the difference was about the same, about a 15% difference in prevalence, with 56% for African American men versus African American women, versus 41% for white women, and then about a 12% difference in prevalence, 59% for African American men versus 47% for white men. So what we can see in this table is that the disparity essentially persisted and remained relatively unchanged, even using the lower threshold, for diastolic and systolic blood pressure. So let's talk a little bit about awareness, treatment, and control. This slide, again, relying on NHANES data, first from the period 1999 to 2006, and then more recently from 2007 to 2014. In the leftmost column, we have different race sex groups. And then in the columns to the right, we have awareness in each time frame, NHANES time frame, then in treatment in each NHANES time frame, and then finally control. And so awareness is defined as people who essentially were aware that they had a diagnosis of high blood pressure. And what we see here is that going from the initial time frame, 99 to 2006, to 2007 to 2014, the more recent time frame, for every group, the awareness increased. And we see that going from each column in each row, that awareness increased in that time frame. And awareness, for the most part, hovers in the roughly 70 to 80% range. And when we look at treatment in the next two columns, we see a similar pattern in that going from the prior time period to the more recent time period for each race sex group, we see an increase in the prevalence of treatment. And treatment is defined by being on an antihypertensive medication. And what we see is that overall, the percentage of persons who are treated is lower than the persons who are aware. So there's a drop-off. However, going from the earlier time period to the later time period in each category, we see that there has been improvement both in awareness and treatment. And this likely is the result of tremendous public health awareness efforts that have been conducted over the years to really help people understand what hypertension means and helps folks to understand the need to be on therapy once they're diagnosed. Now moving to the last two columns, let's look at control. So this is defined as, and this is using, because this data is pre-2017, excuse me, we're using the old guideline or old threshold of 140/90. We see that, again, there is improvement in control going from the 99 to 2006 period to the 2007-2014 period. And however, what we find overall, though, is that the overall numbers drop dramatically looking at control. So whereas with awareness, we were oftentimes looking in the 60 to 80% range, with control, for each group, none of them surpasses the 60% mark. So while we have done a very good job of increasing awareness, getting people on treatment, we still have a ways to go in terms of getting them under control. And what's more here is when you compare African American women to white women, you see that the rates of control are less, 53% for African American women compared to 58% for white women, and the same can be true when comparing males across different races. African American males with a control rate of 41% trail behind white males with a rate of 53.9%. So not only are we overall not doing a good job with control, or as good a job with control as awareness and treatment, there are still some race gender groups that lag behind as well. So let's talk a little bit about geographic variation in hypertension prevalence. This is a map of the U.S., and it shows the prevalence of hypertension color-coded onto all 50 states. And the numbers here are less important, but the most important thing on this slide is that the darker the shade of red, the higher the prevalence of hypertension. And you can see that Alabama is right square in the middle of a group of southern states that all fall into the highest category based on prevalence of hypertension. And that is a trend that has existed now for years, and we see it year in and year out. And as a state, we find ourselves geographically right in the center of it. The prevalence of hypertension in Alabama, unfortunately, does not compare favorably with the prevalence nationwide. This graph looks at the prevalence of hypertension in Alabama over time. And on the y-axis, you have the percentage of adults who have hypertension. And on the x-axis, you have years over time. The circle, the line with the demarked by the circles is prevalence in Alabama. The line with squares represents prevalence in the U.S., and you can see going all the way back to 1996 that prevalence rate is higher in Alabama, and honestly, it almost seems to be getting wider as we get to 2016 on the far right. So that, in and of itself, is disconcerting relative to the challenges we faced here in our state. So let's talk a little bit about some of the more specific disparities with hypertension that are present within the state of Alabama. This is from America's Health Rankings. This is an organization that ranks the health of states on an annual basis and uses a multitude of national surveys and other publicly available data to compile those rankings. As you can see, our ranking is 49th, and that means that there's only one more state that has a higher prevalence of high blood pressure than Alabama. And then on the rightmost rightmost panel, we can see differences by race and ethnicity among adults over the age of 20. There's a 39.1% prevalence of hypertension among whites. When you look at African Americans, that number increases to almost 47%. Slightly or much lower among Latinos at 17.5%, and among Native Americans, roughly 25%. So we can see here that the disparities that we saw nationwide with African Americans having higher prevalence of hypertension relative to whites exist here in our state as well. When we look at how that has changed over time, there's some concerning evidence that it may be getting worse. This is data from the Association of State and Territorial Health Officers, and what they have done in this table is looked at the estimates for the total population in 1999 compared to 2009, and you can see in the top row in the two leftmost columns, the prevalence was 31.2% in 1999 and 37.1% 10 years later, representing an almost 20% increase. When you look at African Americans alone, it went from 36.4% in 99 to 43% in 2009, representing an 18.4% increase. And then among whites, went from roughly 30% to roughly 35% over the 10-year time span, representing a 15.4% increase. What's concerning is the disparity or the difference between African Americans and whites actually increased from 19% to 22% over that 10-year time frame. So again, evidence that the disparities in Alabama may be getting worse over time. This is, again, data from America's health rankings. And we've been focused on race, but of course race is not the only metric that we utilize to look at disparities. One other common one is household income. And looking here, we see that the prevalence also varies by household income as well. And in this graphic in the rightmost panel, we see high blood pressure prevalence relative to household income. And in the top row, we see that roughly in those making less than $25,000 annually per household, the prevalence is a whopping 53%. For those in the next stratum, from 25,000 to just shy of 50,000, it's 44%. From those in the next high stratum extending to 75,000, it's 40%. And then those in the highest stratum over 75,000, 31%. So as you can see here, there's a lot of variation depending on the household income. Sort of along that same theme, we see that the prevalence varies according to educational attainment as well. In the rightmost panel, for those making those with less than a high school education, again, we see over half of adults have hypertension. For those who have a high school diploma, it's just shy of 50%. For those with some college and college graduation, we see respectively lower numbers, but still not small. And in addition to some of those factors that are related to socioeconomic status, we also see some variation based on place of residence. So in this slide, we're looking at urban versus suburban versus rural and prevalence in those three groups. Roughly 50% prevalence in those living in urban areas, slightly lower at just shy of 47% in suburban areas. Folks living in rural areas seem to be hit the hardest with over 50% prevalence of hypertension. And I just want to remind you all that, we're talking about in those rural areas and for some of those other categories that I've shown on previous slides, essentially 1 in 2 people. That you're hard-pressed to find disease states with that level of prevalence in our state or in any other state. So I just want to take a little bit of an extra time so that people can let that sink in. So we've talked a lot about the prevalence of hypertension, and so what does this mean? Of course, hypertension, we all know, has all manner of complications, some of which we'll touch on, but it also can lead to death or mortality. And this slide shows cause-specific mortality for a number of different things, hypertension being one of them, and it's based on vital statistics mainly taken from death certificates. And we can see on the y-axis, we see the percent of total deaths, and then on the x-axis, we can see the different groups based on the cause of death. And then the blue bars represent data from 2000, whereas the green bars represent data from 2013. So for heart disease, the leftmost pair of bars, we see that there was an actual drop in cause-specific mortality related to heart disease from 2000 to 2013. Skipping over, we see the same is true for stroke. Though the prevalence is lower than heart disease, we see it too drop. The cause-specific mortality dropped from 2000 to 2013. When we move back leftward, though, we see that hypertension essentially stayed the same. Despite the passage of 13 years and despite the trends we've seen in those other two disease states, the cause-specific mortality has remained roughly, or actually exactly the same from 2000 to 2013. This would suggest that we have more work to do to figure out how to reduce cause-specific mortality related to hypertension. So let's look a little bit at disparities in hypertension-related mortality. This graph is also based on vital statistics data from the federal government, and on the y-axis we have the number of deaths per 100,000 population, and then on the x-axis we have the year spanning from 2000 to 2013, and the lines represent the trend in the number of deaths per 100,000 over that time period. And the blue line at the top represents death rates among non-Hispanic blacks, and the two lines, the green line represents whites, and the dotted blue line represents Latinos. And as you can see, throughout this time period, non-Hispanic blacks have a much higher hypertension-related mortality rate than the other two groups. It appears that the gap may be narrowing as we get out closer to 2013, but still a very wide gap between African Americans and the other two groups. So let's talk a little bit about hypertensive complications. This is just a graph showing a number of studies measured in aggregate and looking at the risk of hypertensive complications based on systolic blood pressure represented by the dark boxes and diastolic blood pressure represented by the lighter gray boxes. And you can see that there are a number of conditions here that are significantly related to hypertension, peripheral arterial disease, hemorrhagic stroke, and a number of others that we routinely see stemming from poorly controlled hypertension. So let's talk a little bit about risk factors. The risk factors for hypertension are probably well known to many who are listening, but they include demographic factors, including age, race and ethnicity, lower educational status, SES. For those factors, those demographic factors, you've seen a good bit of data that I've presented to confirm that there are certain groups based on those categories that are a higher risk for hypertension. It's also an increased risk based on some genetic and hereditary factors. So folks who have a family history of hypertension or other genetic factors that may be related to higher incidence or prevalence of hypertension. There are also some data to suggest that psychosocial stressors increase the risk of hypertension. This data is more burgeoning than some of the other data related to demographic factors, but we really are beginning to make links between psychosocial stressors, hormonal responses, and incidence and prevalence of hypertension. So really beginning to map out the physiologic pathway through which psychosocial stressors lead to higher blood pressure. There are also certain comorbidities, sleep apnea is one example, and then a number of behavioral and lifestyle factors, including lower physical activity or sedentary behavior, a higher BMI, which of course suggests excess weight, and tobacco use. And in addition, a number of dietary factors. Dietary fats can lead to higher risk of developing hypertension. Higher sodium, lower potassium, and certainly excessive alcohol intake is associated with a higher risk of hypertension as well. So this slide looks at the cumulative risk of developing hypertension based on over 80,000 participants in the Nurses' Health Study. And I want to draw your attention to the column on the left, which in that first row shows the risk of developing hypertension for folks who've have the highest adoption of the DASH diet. The DASH diet, I'll discuss it a little bit later on, but is high in potassium, low in sodium, and high in fruits and vegetables. So folks who are doing the folks who are doing best in terms of adherence to the DASH diet, folks who engage in daily vigorous exercise, and folks who have a BMI less than 25. If they had all three of those factors, then they were able to cut their risk of hypertension, developing hypertension, in half. When you go down to the next row, if you added to those factors low alcohol intake, they were able to decrease their risk for hypertension to developing hypertension to almost 40%. If to those factors they added use of aspirin or some other NSAID, dropped down to below 30%. And then finally, if they supplemented with folic acid, then the risk dropped down to almost 20%. So again, we can see here that there really is an incremental and cumulative advantage to adopting some of these lifestyle changes to reduce your risk of developing hypertension. And this slide shows one of the areas where we, I think, struggle the most clinically, looking at the risk of hypertension associated with the consumption of sugar-sweetened beverages. Sugar-sweetened beverages can be defined as anything such as sodas that are not diet, powdered drink mixes, again, that are not diet. And this slide looks at a number of cohort studies in aggregate and shows that the risk of increased sugar-sweetened beverage intake, as the risk of developing hypertension is about 20%, increases the risk by about 20% for those who have higher intake of these types of drinks. And how do we compare in the state of Alabama in terms of our adoption of these lifestyle factors that play a role in the development of hypertension? Again, you have a map of the United States, and this is data based on the behavioral risk factor surveillance system from 2013. And as we have done on the previous map, I'm not going to focus so much on the actual numbers, but the lighter the shading, the lower the adoption of some of these lifestyle changes. So you can see here that our state, Alabama, is the lightest shade. It has no shading at all, meaning that we, as a state, are not doing a very good job relative to other states of adopting healthy lifestyle behaviors. When you look at the individual behaviors that are often recommended, we can look here at Alabama, and we can see that for maintaining a normal weight, meaning a BMI less than 25, about 20% of adults are meeting that mark. When we look at not currently smoking or being a former smoker. About 70% of people fall in that category. Limited alcohol intake, we're not doing badly here. About almost 95% of people fall in that category. People that are taking in the recommended amount of fruit and vegetables, only about 11% of adults in Alabama. For those who are pursuing the recommended amount of physical activity, not quite half. So for diet and exercise, you can see there's a lot of room for improvement. When we look at all 5 behaviors, and admittedly adopting all 5 can be daunting, but when we look at all 5 behaviors, we see less than 1% of adult Alabamians have adopted all 5. So there's a tremendous amount of improvement with regard to lifestyle changes to reduce our collective risk as a state of developing hypertension. In addition to some of the other factors that I've mentioned, lifestyle, demographics, there also are some structural factors related to the healthcare system and the way people access care that also can complicate their management of their hypertension. And what this slide does is it shows, again, using the behavioral risk factor surveillance system data, this time from 2011, shows a number of factors that can complicate seeking care and looking at the prevalence of those factors among the different states. And in each case, the darker the shading, the more prevalent the factor. So you can see among those with hypertension who lack health insurance, Alabama, in this instance, is not the most darkly shaded, not part of the most darkly shaded group, but it's in the next to the most darkly shaded group. So not the worst, but still room for improvement there. Among those with hypertension, with people lacking a personal doctor or healthcare provider, interestingly, Alabama's not doing badly here in one of the lighter shaded groups relative to the other states. However, when we go to the last panel, C, and look at those with hypertension who are unable to see a doctor due to cost, again, we're in the group that's worst off, the most darkly shaded group here. So even once adults are diagnosed with hypertension in Alabama, there still are some challenges that they may face in terms of seeking care and getting their blood pressure under control. So let's spend just a little bit of time here toward the end talking about the evaluation of the hypertensive patient. When patients come in and they're either have been diagnosed with hypertension or there's a concern that there might be a new diagnosis of hypertension, history is key. We want to assess as to whether or not there have been any prior cardiovascular disease events. This includes transient ischemic attacks or full-blown strokes. We want to assess them for history of coronary artery disease or heart failure, as well as peripheral arterial disease. We also want to assess for comorbidities that we have already mentioned are related to the risk of developing hypertension or worsening of hypertension, and those include diabetes, chronic kidney disease, sleep apnea. For the physical exam, there are a number of fundamental things that we want to make sure that we do. Obviously, measuring the blood pressure is essential, but we also want to measure BMI and waist circumference to see how the person's body habitus may be impacting their ability to control their hypertension. We want to do a full neurological exam to ensure that there are no existing neurological deficits that might signal that the patient has already had an event related to his or her hypertension. We also want to look for signs of heart failure and look for peripheral pulses as a means of ensuring that there's been no arterial damage in the peripheral vasculature. And then finally, an ocular exam to make sure that there have been no hemorrhages related to uncontrolled blood pressure. In terms of labs, we want to look at electrolytes, particularly looking at kidney function, fasting glucose or hemoglobin A1C to look for the presence of diabetes. Serum creatinine and BUN can also obviously give us some idea about renal function, as well as urine albumin to see if patients have already begun to spill protein in their urine because of uncontrolled hypertension and glomerular damage. In terms of hypertension risk factors, we also see that there are racial differences here and disparities that exist here. We talked about some of those comorbidities that we want to look for. This is looking at NHANES data from 2005 to 2012. On the leftmost column, we have CVD risk factors, and in the rightmost column, we have either mean measurements for each of either mean measurement for serum assays or prevalence. So, for instance, we see in the first column represents African Americans. The second column represents whites. And so, for instance, when we jump down to diabetes, we can see that African Americans have diabetes and/or chronic kidney disease. 56% of African Americans with hypertension also have diabetes and/or CKD, and that number is significantly smaller, only 40% for whites. When we look at the total CVD prevalence, this includes stroke, coronary artery disease, heart failure, peripheral arterial disease. That number is higher in African Americans at roughly 24% versus 21% in whites. So even when we're looking among folks with hypertension, we see that these risk factors also vary by race as well. In terms of measuring blood pressure, we want to be very careful about cuff placement. We really want it over the upper arm, directly on the skin, to use it measuring blood pressure with the brachial artery versus the finger or the wrist. The measurements with the brachial artery have been shown to be more accurate and more reflective of actual blood pressure than those more peripheral measurements. Correct cuff size is important. If a cuff size, the most common mistake is putting on a regular size cuff on someone who has a larger than average arm. This can artificially inflate the blood pressure and can lead to erroneous measurement. So you want to make sure that the cuff size is appropriate for the size of the person's arm. The auscultatory method is still preferred by many over the electronic oscillometric monitor or the electronic monitors. Obviously, people have to use what's available, but sometimes if there is a reading electronically that seems off or doesn't fit with the person's history, it may be a good idea to check it with the auscultatory method as well, just to be sure. So, tips for accurate blood pressure measurement. This is a graphic that was put out by the American Medical Association, and I'm not going to go through all of these factors, all 7 tips, but it just gives a really clear idea about the number of different things about posture and other circumstantial things around measuring blood pressure that can really dramatically affect blood pressure. We try our best in clinical settings to adhere to all these things. It can be difficult logistically to do that and maintain workflow in a clinical setting, but I would encourage everyone to take a look at this as a reference and make sure that the ones that are feasible that you're doing to make sure that you get the most accurate measure when checking blood pressure on patients. So, lifestyle counseling is a incredibly important part of managing blood pressure. With diet, the 2 biggest things are decreasing sodium, discouraging people from adding salt to their diets, as well as having them increase potassium. So potassium-rich foods should be encouraged, certain fruits, as well as green leafy vegetables, and then weight loss. One of the things that I talked about earlier was the DASH diet, which is low in sodium, high in potassium, and encourages fruit and vegetable intake, encouraging physical activity, encouraging minimal to moderate alcohol intake, but staying away from excessive alcohol intake. And this really means up to 2 drinks daily for most adults. Smoking cessation is also important. So for tobacco users, quitting smoking can help with high blood pressure management, excuse me. And then I think always looking for opportunities for improvement among African Americans for all of those lifestyle factors. There are a number of disparities that exist for African Americans with some of adherence to some of those lifestyle changes. And as providers and public health officials, we have to make sure that we particularly encourage these changes among African Americans. This slide just gives an outline of the DASH diet. I meant it more as a reference. I'm not going to go through it, but it really gives an idea about what the eating plan looks like with the DASH diet. It's something that can be downloaded at the website address shown underneath, and may be a useful reference to share with patients or to review with patients when giving them advice about dietary modification. And sort of in keeping with the need to really encourage African Americans in particular to pursue some of these lifestyle changes. This is data from a study looking at racial differences in the benefit of the DASH diet. And in the panel A, it shows the drop in systolic blood pressure, and stratifies that by hypertension category, so those who have normal blood pressure versus those who have hypertension, and then sort of an overall look. And the green bars represent the drop in blood pressure for systolic blood pressure for African Americans, and the orange bars represent the drop in blood pressure for whites. And as you can see, in the folks who were classified as pre-hypertensives, African Americans experience a larger drop in blood pressure, almost 4 millimeters of mercury relative to whites. In those who had hypertension, the difference was even greater. African Americans having an almost 14 millimeter mercury drop in blood pressure compared to only about a 6-point drop in blood pressure for whites. And that disparity held when you looked at them overall. And the same was true for diastolic blood pressure. You can see for all 3 categories, the normal persons who were with normal blood pressure, the folks who had higher blood pressure, and then the overall group. In each group, African Americans experience a greater benefit from adherence to the DASH diet compared to whites. So physical activity, for most healthy people, we really recommend 150 minutes or 2 hours and 30 minutes per week of moderate intensity physical activity. Probably the best example of this is brisk walking. Physical activity should be performed in episodes of at least 10 minutes, and preferably it would be spread throughout the week. The physical activity should be preceded by flexibility and stretching exercises, and it's also good to include muscle strengthening activity at least 2 days each week as well. With that, we are at the end of the talk. I hope that this has been helpful for you all in thinking about disparities related to hypertension, as well as disparities in risk factors, and then finally a review on the evaluation and non-pharmacologic management of patients with hypertension. Thank you very much.
Thanks, Dr. Durant, for talking to us about health disparities related to hypertension. Our next speaker is Dr. George Howard of the School of Public Health at the University of Alabama at Birmingham.
Good afternoon. My name is George Howard. I'm a college professor at the University of Alabama at Birmingham in the School of Public Health, and today we'll be discussing what might be contributing to the excess stroke mortality in African Americans. To begin with, globally, stroke is a terrible problem. It's a huge public health burden. Every year, almost 800,000 people experience a stroke, and every time people put out numbers like that, they're sort of meaningless in the abstract. But basically, that's more people than live in Vermont or North Dakota, and so every year more people have strokes than live in Vermont. In addition, many of the people survive the stroke. Right now in America, there are about 7.2 million people living with the impact of a stroke. I'm sure many of you have relatives or friends that have survived a stroke. And while some people do well, other people carry a heavy burden of sequelae following the stroke. Again, 7.2 million is a bit of an abstract number, and to put that in perspective, that's more than the population of Massachusetts or Arizona or Indiana. And so if you would just picture, everyone in the state of Indiana, man, woman, and child having had a stroke. But the point of today's talk is while that's bad, it's even worse that the burden falls on some people much harder than it falls on other people. And so I'll start by talking about the temporal change in stroke death. This graph shows the vertical axis is the number of stroke deaths per year, and the horizontal axis is the year. This is the line for whites, and I come bearing good news. There's been, since 1999, about a 40% decline in the number of whites that are dying from stroke. Great news, remarkable declines. Unfortunately, if you put the number of African Americans who are dying from stroke, or not the number, I should say the stroke death rate from African Americans on the same graph, you can see a similar decline. So the good news for African Americans is that it is declining as nearly as fast as the whites. But as you can see, there's a huge gap in the age-adjusted stroke mortality rates between whites and African Americans. If you look at other minority groups, this is Hispanics, Asians, and Native Americans, you can see that all of them are less than whites. And so really if you talk about stroke mortality or disparities in stroke mortality, unfortunately it's generally African Americans versus any other race, ethnic group. On the right-hand side, we're showing the mortality ratio, the ratio of stroke deaths in African Americans compared to their white counterparts. And as you can see, it's about 40% higher in African Americans. The age-adjusted stroke mortality rate's about 40% higher in African Americans than their white counterparts. And of course, the mortality ratio for the other ethnic groups are below whites, the blue line being the rate in whites. A Healthy Person 2010, the guiding document for Health and Human Services, really only had two goals, the second of which was to eliminate, not reduce, but to eliminate racial disparities. Back in 1999, the black to white mortality ratio was 1.36, so a 36% excess mortality in African Americans compared to their white counterparts. Over time, instead of being eliminated or going back down to no disparity, that disparity has actually increased, and the reason for that is that on the left-hand side, the stroke mortality is falling for whites and for African Americans, but it's falling more rapidly for whites than African Americans. So actually, the disparity is increasing over time from 36 to 41%. Unfortunately for African Americans, that 40% is the good news, and the bad news is shown on this graph, where we're looking at the black to white mortality ratio by age, with the bars on the left-hand side, the blue and orange bars, being the black to white stroke mortality at ages 45 to 54 and 55 to 64. So I guess the middle line is a green line. That's ages 65 to 74. And as you can see, at younger ages, the stroke mortality in African Americans is not 40% higher, but 200 to 300% higher. huge disparities between blacks and whites at young ages. This is one of the largest disparities for any disease. It's not the largest, but it's among the largest. If you look at the Hispanic to white mortality ratio, the Asian to white mortality ratio, and the Native American to white mortality ratio, you can see that for no other race ethnic group and for no other age are there disparities that are anywhere in the ballpark compared to what's happening in African Americans. So basically the good news here is that the stroke mortality is plummeting for all race ethnic groups. Over the 18 years shown on the previous graph, it's decreased 40% for whites, but only 38% for blacks. It's decreased 31% for Hispanics and 43% for both Asians and Native Americans. Because of that remarkable decline in stroke mortality, stroke has fallen actually between 2010 and 2016 from being the third leading cause of death in America to the fifth leading cause of death in America. And so there's a lot to celebrate about this decline. The bad news, however, is that on average, stroke mortality is about 42% higher in blacks than it is in whites. And unfortunately, between the ages of 45 to 64, it is not 40% higher, but 200 to 300% higher. And the decline is not as rapid in African Americans as it is in whites. So the black to white disparities are actually increasing, and the magnitude of that increase was 16% over the 18 years in the previous graph. There's more good news, particularly if you're Native American or Asian. Stroke mortality is falling and falling faster than in whites. And in 2016, 11% of stroke deaths in whites occurred below age 65. Unfortunately, that compares to 28% of stroke deaths in blacks happening below age 65. And so imagine, if you would, people who are in the working ages of their life suffering a stroke and being put, some portion of them in nursing homes or requiring intensive care at very young ages. 11% of stroke deaths in whites versus 28% in blacks. Huge differences. So basically, one of the interesting things about what I do for my research is that most people think they know what's driving this difference. When you talk to people about it, they say that the two most common hypothesized reasons for the higher incidence in blacks is that blacks have a higher prevalence of hypertension and diabetes than their white counterparts. So a larger proportion of African Americans are hypertensive and diabetic. And the second reason people very quickly bring up is that blacks have, on average, lower socioeconomic status than their white counterparts. And because of that lower socioeconomic status, there's a presumed less access to health care and poor control of risk factors. Interestingly, if you say that's your opinion, but show me the data, show me how that factors into the black-white differences in stroke, there's really surprisingly little data to support these hypotheses. You can think of those as being more speculative than proven. So if we look under the street light, if you do think it's the hypertension and diabetes and socioeconomic status, remember that we're trying to explain a 300% increased stroke risk in the young blacks. And everybody knows that the prevalence of hypertension and diabetes is higher in blacks than it is in whites. In the study that I'm very honored to be part of, called REGARDS, Reasons for Racial and Geographic Differences in Stroke, we show that 71% of blacks are hypertensive compared to only 51% of whites. So a huge 20% difference in the prevalence of hypertension. In addition, 29% of blacks are diabetic in our study compared to only 15% of whites. Literally almost twice as many blacks are diabetic than their white counterparts. So in Framingham and CHS, which are large studies that have looked at predicting risk and predicting the risk of stroke, what they have suggested is that both hypertension and diabetes roughly double the risk of stroke. And if you take that and apply it to the difference that 20% of blacks that are hypertensive that whites are not, and the 15% of blacks that are diabetic when whites are not, you can predict how much increased risk there should be in the African American community. And the risk should increase roughly 1.7 times or 71%. So basically there's a 300% increase. That's what we're trying to explain. But if we look at the differences in the prevalence, they can only be expected to explain about 71% of the disparity. And so basically 300% is clearly phenomenally larger than the 71%. And so something else is going on. It isn't just, I mean, hypertension and diabetes are important. I'm not saying they're not, but something else is going on also. Something else is going on also. So basically so that raises the question, could the lower average socioeconomic status of blacks contribute to less health literacy or less awareness and treatment for their hypertension and diabetes? And so the hypothesis is, one of the additional hypotheses is that that awareness, treatment, and control could be contributing to the black-white differences, with blacks perhaps, at least what I thought when I went into this, being less aware and less likely to be treated for their hypertension than their white counterparts. Well, one of the joys of doing research, frankly, is being wrong. And so this graph shows the black to white ratio in awareness of hypertension among people who have hypertension. And so, much to my surprise, and much to the surprise of many people, it turns out that blacks are not less aware of their hypertension, but as shown on this graph, about 40% more likely to be aware of their hypertension. That is, if you're a black and you're hypertensive, you're actually more likely to know about it than a white who's hypertensive. So is it treatment? Maybe the fact is that the blacks are aware of their hypertension, but they're not getting treated. Well, the next panel shows the treatment. Again, black to white ratio of treatment for hypertension. And what this shows is that given the fact that you're hypertensive, and you know that you're hypertensive, blacks are about 60% more likely to be treated for it than their white counterparts. So it's not that blacks are not aware of it. It's not that blacks are not being treated for it. What it is that given the fact that you're aware of it and you're treated, is your blood pressure controlled? Do you get your blood pressure below? These are data prior to the current guidelines, so this is less than 140 or 90. And what this shows is that blacks are more likely to be aware, more likely to be treated. But unfortunately, the treatment doesn't work, and they're 40% less likely to have their blood pressure controlled, So basically, even among treated hypertensives, blacks have systolic blood pressure about 5 millimeters higher than their white counterparts. If you're a nurse or a clinician right now, you're saying 5 millimeters, that's a small amount. At the population level, however, a 5 millimeter average difference in blood pressure is a huge impact. And that raises the question, could these differences in the risk factor really be what's driving the differences in stroke incidence? Now, one of the things that I have done on you right now is I've sort of pulled a quick one on you. I've been talking about stroke mortality, and now I'm changing and talking about stroke incidence, or actually having the stroke. Now, what's shown on, and both in Haynes and Regards, in Haynes is another cohort study, have looked at this question. And remember that what we're trying to do is explain a 3 times increased risk in stroke mortality at age 45, but no difference at the older ages. But what is the pattern for stroke incidence instead of stroke mortality? Well, in Regards, the study that I'm honored to be part of, this graph shows the black to white risk of having a stroke, as a function of age, with the dark line being the predicted difference and the lighter lines being the 95% confidence or uncertainty about that line. And as you can see, at age 45, just like the mortality, at age 45, in our study, African Americans are 3 times more likely to have a stroke than their white counterparts. But by the time they get to be 85 years old, blacks and whites have about the same stroke risk. Their ratio of stroke is 1 or no difference between them. And so basically the pattern of stroke incidence nearly perfectly reflects the differences in stroke mortality. So this suggests strongly that it's because blacks are having more stroke that they are at higher risk of dying from the stroke. It's not case fatality, it's not treatment, but blacks having more strokes. So if you think about it, how much of that is because blacks have a worse risk factor profile? So again, the Framingham study, it's sort of the mothership of all of epidemiology studies. They have suggested that there are 6 major stroke risk factors, besides age, by the way, age and sex, but as far as risk factors: hypertension, diabetes, cigarette smoking, atrial fib, left ventricular hypertrophy, and heart disease. Now, blacks have almost, for every one of those, except for AFib, for every one of those, African Americans have a higher prevalence of all of those risk factors. Now, so that raises the question, is this pattern that we're looking at on this graph because blacks have more of these risk factors? And basically you can address this in what's called a mediation analysis. And the idea of this is that I'm going to take those risk factors and I'm going to account for all of the difference between blacks and whites that can be attributed to those risk factors. Now, if the risk factors were really explaining the black-white difference, that brown line would come down and be flat at 1. That would be the case where we explained it all, that it's the reason for blacks and whites is because of the higher prevalence of risk factors in blacks. So, what happens if we adjust for just the Framingham stroke risk factors? Do we come down to that red line? And what's shown on this graph, the brown line again is the unadjusted. The green line is the after adjustment for the Framingham risk factors: hypertension, diabetes, cigarette smoking, LVH, AFib, and heart disease. And I pushed the wrong button. Good. Okay. And so basically, in the range that we're most interested in, those risk factors account for about a 40% attenuation of the black-white differences in stroke risk. So the corollary of that is, so what happens if we further adjust for socioeconomic status? Does that explain even more of it? And so if we additionally adjust for socioeconomic status, we move from that green line to the blue line. So not much of an additional explanation, only a small additional adjustment. The reason for that, many people think socioeconomic status is very important. I do too. But one of the ways it works is through these same risk factors that we've already adjusted for. And so that's not much of an additional attenuation. However, it does account for, bring the total attenuation to about 50%. And the interpretation of that is about half the black-white disparity in stroke risk is because of these traditional stroke risk factors. It was interesting when we were writing this paper, the investigators, the authors, looked at this graph and half of us went, oh, this is great. We've explained half of the variation. This is remarkable. And the other group of people said, oh my gosh, what are we going to do? We only explained half of it. And so basically the name of the paper, the name of the scientific paper is literally the glass half full, because half the authors thought this is great and the other people said this is horrible. And so basically we accounted for about half of the black-white difference. So what can be done to address that half-full portion? In other words, if the only reason, by the way, to understand the black-white difference is to try to make some difference to make it go away. Okay, And so what can we do to make the black-white difference go away for the part that we understand? Well, most of the risk factors, for example, hypertension and diabetes, are being modeled as prevalent disease, absent or present. We're not talking about the effectiveness of treatment, but just whether somebody is hypertensive or diabetic. What this implies is that it's not risk factor treatment that is the key to this half, but risk factor prevention. And we're going to come back to this later. If we really want to make a difference, if we really want to change the black-white differences in stroke risk, we need to shift our attention to from racial disparities in stroke to be racial disparities in stroke risk factors. What we need to do is to understand why African Americans are more hypertensive and diabetic, and change that. And that when we say going upstream, we'll do that later in this talk a little bit. Okay, but if we explained half the difference in the black-white difference in stroke risk, there's also half that we didn't explain. What could that other half be? What could that other half be? Half of it is the risk factors. What is the other half? Well, it could be differential susceptibility to risk factors. Maybe having a blood pressure of 160 if you're African American is worse for you than if having a blood pressure of 160 if you're white. It could be something called residual confounding, which is a fancy way to say we don't do a very good job of measuring these risk factors. Hypertension is a good example. We bring people in, we put a cuff on, we take one blood pressure. That really doesn't reflect their 24-hour blood pressure pattern at all. In addition, it doesn't reflect different aspects of hypertension, such as the duration that someone has been hypertensive, with African Americans developing hypertension at much younger ages than their white counterparts. The third thing it could be is non-traditional risk factors. Could it be discrimination that African Americans are discriminated against, which is leading them to be at higher stroke risk than their white counterparts? Could it be inflammation? There are a lot of other risk factors that aren't part of the six: hypertension, diabetes, cigarette smoking, AFib, LVH, and heart disease. And finally, it could be something called measurement error, and I won't go there, but basically there are assumptions in these models that are almost certainly violated in how well we measure these different risk factors. So let's take a minute, though, and look at that idea of differential susceptibility and say, for every 10 millimeters difference in blood pressure, how much does your stroke risk increase? And what this graph shows is that for blacks and whites together, B and W, blacks and whites, for every 10 millimeters of mercury higher blood pressure, your stroke risk increases about 14%. 10 millimeters, 14%, 20 millimeters, 28%, so on. Okay? But what happens if we look at it separately for whites and blacks? So if you look at it in whites, for every 10 millimeters, the risk increases 8%, only about 8%. While in blacks, same 10 millimeters, but a 24% increase in risk. And so what's happening is for the same 10 millimeters, the response in the African American community is 3 times greater than in the white community. In other words, the same 10 millimeter difference is 3 times worse for a black person than a white person. And so there are a lot of things going on now. This is beginning to be a little bit complicated. Gee, it hurts my head a little bit. But there are a lot of interactions going on between race, age, and systolic blood pressure. You know, we've been talking about it. Young ages, the black-white difference is bigger. And so what I want to do is to consider the black-white differences in stroke risk within strata of age and strata of systolic blood pressure. In other words, let's look at them for specific ages and for specific levels of blood pressure. Now, what's shown on this graph is the black-white difference in stroke risk. The faster those lines are coming down, the more people are having strokes. So that's vertical axis of this graph is the number of people stroke-free. And this graph is shown for blacks and whites who are young, 65 years old, less than 65, I beg your pardon, but are normotensive. Blood pressure is less than 120. Well, two things are apparent on this graph. The first is there aren't, despite the fact most of the stroke risk is happening under age 65, here the blue line for blacks and the red line for whites are nearly on top of each other. In fact, the red line is a little bit below the blue line, saying that there's a little bit more stroke in the whites than the blacks, if you're normotensive. In fact, the hazard ratio, or the relative risk, is 0.87. That's the black to white hazard ratio, which says that for young blacks who are normotensive, there's 13% lower stroke risk than their white counterparts. Lower stroke risk than their counterparts. If you're normotensive, if your systolic blood pressure is less than 120. So this slide is out of order. I should have noticed that, but what I'm doing is looking at this in different age strata. So this is 65 to 74, and 75 plus, and these are the blood pressure categories I'm looking at. And here's the same graph again, and here's the same thing. And so basically we're looking at normotensive young people. And remember, it's less than 65 is what I am primarily interested in, trying to understand why we have that extraordinary stroke risk in young blacks. So I'm going to take that graph, and what I'm going to do is there it is again, is to park it in the upper left-hand corner of this slide. So the top row of this are going to be the young people, less than age 65. 65 to 74 is the second row. Over 75 is the third row. And the columns are going to be normotensive, pre-hypertension, blood pressures between 120 and 139, and stage 1 hypertension, blood pressures above 140. This is exactly the same graph you saw on the previous slide. How about black-white differences in other ages? Well, you can look at these graphs and say, my goodness, the red line is right on top of the blue line. You can look at the hazard ratios and say that there's no more than about a 10% difference in the black-white differences in stroke risk. If you're normotensive, the black-white difference in stroke risk goes away. How about if you have pre-hypertension, blood pressures between 120 and 139? The red line is beginning to come down below the blue line here, particularly at the young ages. In the top box here, the 1.38 says that the risk is 38% higher in blacks than whites if you're young and have pre-hypertension. If you're young and have pre-hypertension. As you get older, that difference becomes smaller, but as you get older, the black-white difference gets smaller for everyone. How about if you have stage 1 hypertension? Now you can see the red line is clearly separating from the blue line, clearly separating. The young people, less than age 65, that top row, the one that I'm mainly interested in, you can see the really clear separation in stroke risk with the red line for African Americans being clearly below the blue line for blacks. And the hazard ratio is 2.38, which says that blacks are at 238% higher stroke risk than their white counterparts. So what this is really saying is that in that young age where we see that huge extra burden of stroke, it seems to be tightly tied with this greater susceptibility to blood pressure. Once you get into that higher stage 1 blood pressure, you can see that the black-white differences really rapidly expand. Now, for the clinician and nurses that are listening, you're probably saying, what happened to stage 2 hypertension? Why is there not a fourth column here where we look at blood pressures above 140? When we began to write this paper, we were very interested in doing that, and 5% of blacks have stage 2 hypertension, systolic blood pressures above 160. Less than 1% of whites have stage 2 hypertension. And if we're going to talk about black-white differences, we have to have blacks and whites, and there aren't enough whites with stage 2 hypertension to talk about black-white differences in stage 2 hypertension, which is why there's no column here. And although I don't have the data, I have the personal belief that the differences there are even much more dramatic than for stage 1, a statement made without data. So basically, if you think about systolic blood pressure and what happens to stroke risk, it's sort of like for African Americans, strike 1, 2, 3, you're out. Okay, so strike one against African Americans is they're more likely to be hypertensive than their white counterparts. Again, 51% of whites, 71% of African Americans, a lot more hypertension in African Americans. Everyone knows that. Strike two is African Americans are more likely to know that they're hypertensive, and they're more likely to be treated, but they're less likely to have their blood pressure controlled than their white counterparts. The black-white ratio for control is about 0.7, which says you're 30% less likely to be controlled if you're black. Fewer people know that. And what we've just seen is that once the blood pressure is not controlled in African Americans, it's 3 times worse if you're black than if you're white. So what happens with blood pressure and the black-white differences in stroke is blacks have more hypertension. Once you have hypertension, blacks are less likely to have their hypertension controlled. Once they don't control their hypertension, it's 3 times worse for blacks. So it's not just the prevalence of hypertension, but prevalence, control, and susceptibility are all playing important roles. So what's happening to the second part of this? So the returning to the half-empty portion. How about the non-traditional risk factors? Can we look at any of these non-traditional risk factors? Dr. Suzanne Judd, who works with me, has done, I think, just extremely interesting work doing this, looking at dietary patterns and how that influences stroke risk between blacks and whites. And what she did was again, in the REGARD study, she took food frequency data, which is exactly what it sounds like. We just simply asked people how frequently they eat different types of foods. And she did a factor analysis, an analysis to try to put people into different groups by their eating patterns. So these are people who eat this way, and these are people who eat that way, and tried to put them into different groups. And over time, when she wrote her paper, there weren't but 490 strokes that occurred during this period. And what she tried to do then was look at these eating patterns and see if people in different eating patterns are at different stroke risk. Okay, different stroke risk. And so the first eating pattern that she had are these food: beans, Chinese food, Mexican dishes, fried potatoes, pizza, salty snacks. And she, so a group of people, this is the main thing some Americans eat, and she labeled these people on a convenience diet, people who eat food because it's convenient for them to eat it. The second eating pattern were beans, whole grain bread, fruit, poultry, soup, vegetables, exactly what your American Heart Association tells you should eat. And she termed this group of people who are eating the healthy diet. The third group of people tended to eat, and this is remarkable to me, candy, condiments, high-fat dairy, chocolate, desserts, salty snacks. And she called these people the people who are eating sweets and fats. Okay. The fourth eating pattern, in other words, different groups of people fall into these, are people who eat added fats, white bread, eggs, fried foods, organ meats, processed meats, sugar-sweetened beverages. If you're from Alabama, you can read sweet tea. And she called these people who are eating the Southern diet, which, if you speak like me, is basically this is everything my mother fed me when I was growing up. And the fifth eating pattern were people who eat butter, coffee, liquor, green vegetables, salads, that is, and wine. And she called this the alcohol and salads diet. And so most people fall into one of these 5 eating patterns. So what happens to the risk of stroke in each of those eating patterns? And so first of all, let's look at the convenience diet and compare this to people who don't eat, who are very low on the convenience diet. And so as you eat more and more of the convenience diet, so this is moving from the first quartile to the second quartile, your stroke risk goes down just a little bit. Second quartile to third quartile goes down a little bit more. The next quartile, the people who eat the most of it, it's back being flat. The vertical bars there are the uncertainty about the estimate. And so basically people who eat very little of a convenience diet are really at about the same stroke risk as people who eat a lot of it. And this was a big surprise to Dr. Judd. This is not what she anticipated seeing. How about the healthy diet? Well, if compared to people who eat the least of it, if you eat more of it, your risk goes down. Your stroke risk goes down if you're in the second quartile. If you eat more of it, it goes further down. If you eat more of it, it's really about the same. So the more of the healthy diet you eat, the less your stroke risk is. And so eating healthy diet, not surprisingly, was good for you. Much to her surprise, if you look at the sugar and sweets, again, the less compared to the second less, about the same, then it decreased, and then it decreased more. And one of the reasons for doing research is you don't know the answer. If you knew the answer, you wouldn't be doing the research. But this is not what she was anticipating. She was not anticipating people who eat a lot of sugar and sweets have lower stroke risk. If you eat the southern diet compared to people who have the least, it's about flat, then it increases quite a bit, and then it increases even more. Okay, and so eating more of the southern diet, higher stroke risk. And then finally, alcohols and salads, basically it had no real impact. So the findings of this, if you add the p-values to the bottom of this, eating a healthy diet was clearly associated with less stroke risk. Eating sweets and fats, to our surprise, lower stroke risk. Eating the southern diet, much, much higher stroke risk. If you adjust for other factors, some of the differences go away, but still that southern diet is associated with increased stroke risk. So could the southern diet have something to do with the racial disparity? And so if there are sort of these interesting and to us sort of depressing patterns in these eating patterns where basically the southern diet was associated with higher stroke risk, and turns out, although I haven't shown you those data, higher risk of heart attack also. And there's a suggestion that, only a suggestion, that the healthy eating pattern is protective. And there's strange findings, things we didn't anticipate, with sugar and fats actually appearing to be protective. And the convenience diet, which we thought would be really bad for you, wasn't really associated with a difference in stroke risk. But although Dr. Judd called it the southern diet, it turns out that African Americans eat more of the southern diet regardless of where they live. Fried foods, organ meats, sweet tea, added fats, added sugars. In fact, if you look at the percent of African Americans in the quartiles of the eating pattern, among the people who eat the least of the southern diet, only 9% of them are black. In the second group, 24% are black. In the third group, 40% are black. And in the highest group, 60% of the people who eat the southern diet are African Americans. And so basically, although it's called the southern diet, she actually could have called it the African American diet, because that's what African Americans are eating a lot more of. And adjusting for that southern diet actually explained nearly 63% of the black-white differences in stroke risk. I will argue this is great news, because this gives us a target. This gives us something we can try to intervene on, something we can try to change to reduce the black-white differences in stroke risk. So the final thing that I want to do is this idea of going upstream and looking at why is it that African Americans have more hypertension in the first place? What can we do to change that? And remember that 40% of the black-white difference is because of that higher prevalence. And if we want to do something, if we really want to change that 40%, what we have to do is called primordial risk factor prevention, prevention of the development of the risk factors. What we need to do is figure out what it is that makes African Americans more hypertensive and make changes there so that they won't become hypertensive. Now, a lot of the attention of primordial risk factor prevention has been on children and adolescents. In other words, we think, oh my goodness, we need to stop African Americans from being hypertensive. Let's focus on teenagers and people 20 years old, because that's when African Americans are really developing their hypertension. Again, the reason for doing research is to prove that you're wrong, and what's shown is it turns out as the population ages, the attention usually turns to risk factor control. We spend a lot of time talking about blood pressure control in the elderly. Should we also be talking about preventing elderly people from developing hypertension? And so what's shown on this graph is, I apologize for how small this is, but is the risk of incident hypertension over a 10-year period. Okay, over a 10-year period. And what this says is overall for all ages in regards, for people 45 and over, if you are sitting there and looking at a normotensive person in front of you, there's about a 50% chance, regardless of their race and sex, for them being hypertensive in 10 years. And if you look at it by age strata, the first bars are 45 to 55, and the ones on the right are over 75. This says that it's really pretty independent of the age. So basically, if you have a normotensive 75-year-old person in front of you, there's about a 50% chance they're going to be hypertensive in 10 years. Let me say that again. 75 years old, we think, oh, I got to control the blood pressure. We need to be changing gears. We need to be saying, no, we need to be preventing hypertension in middle-aged and older Americans. On the right-hand side of this shows the black to white difference, and basically you can see that blacks are at 50% higher risk of developing hypertension regardless of the age. And so basically what's happening is even up to age 85, African Americans are developing more hypertension than their white counterparts. So, if to address the 40% to 50% of excess stroke risk in blacks that's attributable to these traditional risk factors, we're going to have to go upstream and figure out what it is about blacks that makes them hypertensive and try to stop them from developing hypertension. Bold goal. And so what kind of things could be related to developing hypertension? Well, it could be socioeconomic status. It could be lower education, lower income. Could be physiological measures. BMI, waist, and sleep apnea could be higher in blacks. It could be environmental factors, poor neighborhood characteristics, and low quality of the neighborhood could be stressing African Americans and having them be more hypertensive. Could be lifestyle choices, alcohol use, physical activity or lack of physical activity, and low mobility. And finally, it could be psychosocial factors such as depression or stress or discrimination or social support. Which one of those things are actually driving African Americans to be more hypertensive? Finally, it could be diet factors, low DASH diet, the low Mediterranean diet. Our friend, the Southern Diet Score that we've just been reading about. Or it could be sodium and potassium intake with a higher sodium, lower potassium intake in African Americans. And so basically what this final bit of information that I'd like to share is a three-stage analysis plan where, number one, we say, of that shopping list of different things that could be driving the black-white difference, which one of those are more common in blacks? Okay, which one of those are the things that blacks have more of? The second stage is, of those things, which one of those are related to hypertension? Because if you have number one and if you have number two, in other words, if blacks have more of something and it's related to the development of hypertension, that's the combination that's going to be leading to higher hypertension in blacks. Very, very importantly, if there's no difference between the black-white rate of these things and it's related to development of hypertension, well, it's still related to hypertension, but it's not going to explain the black-white difference because blacks and whites have the same amount of it. Conversely, if blacks have more of it and it's not related to hypertension, then it's a shame blacks have more of it, but it's not related to hypertension, so it won't explain the black-white difference. So for something to explain the black-white difference in hypertension, blacks have to have more of it, and it has to be related to the development of hypertension. So the third step is to calculate exactly that. What percent of the black-white disparity in the development of hypertension is related to those? So looking at this, I'm guessing that you are having a hard time reading this on your monitor, but these are exactly those factors. The top one is low education, then low income, and then down at the bottom of the different diet factor scores. So which one of these are more prevalent in blacks, of that shopping list of different things? And the things that are shown in green here are factors that are more common in blacks. So this is bad news. This is bad news because most of those things that we think of as potentially relating to hypertension, the rates of them are higher in blacks. I hope you can read this a little bit, but this is the discrimination score. Not surprisingly, African Americans are exposed to more discrimination than their white counterparts. Basically, if it differs by 2 standard deviations, it's significant. This differs by 21 standard deviations, and so blacks are seeing incredibly more discrimination. Blacks are also seeing, as we've talked about before, much more of the Southern diet score, much more of the Southern diet score. And finally, they are seeing less of selected things, and actually I'm having trouble reading that from here, but, it's waste and one other factor. But anyway, certain things blacks don't have as much of, but most of the things, the green, most of the things that we think are related to the development of hypertension, unfortunately, blacks have more of those conditions. Second stage of this is to look at which one of those very same factors are related to the development of hypertension. And again, here shown in green are the things that are related to hypertension. Okay? It is interesting that discrimination, although blacks have more of it, at least in our data, is not related to hypertension. And so even though blacks are more exposed to discrimination, discrimination is not driving the development of hypertension, so that can't be the reason for the black-white difference. So finally, what are the things that really drive the difference? And here it shows that the list gets to be very, very short. Only the things in green are the things that appear to be mediating the black-white difference. Interestingly, our old friend, the Southern diet, explains 50% of the black-white difference in the development of hypertension. Again, great news, because now we have something that we can begin to target and begin to try to change to reduce the black-white difference. The second biggest thing is the neighborhood. What type of neighborhood are you in, and how does that stress you? The third thing is income, and then the fourth thing is the sodium-potassium ratio. So basically 2 out of the 4 have to do with diet, with the Southern diet being just completely dominant, really explaining the huge difference. If we play the same game in women, so black-white differences in women, again, lots of green. African American women have a lot more of the factors that are likely to be related to hypertension. In women, though, more things are related to the development of hypertension. Again, many more green things here. And if you look at what actually mediates the difference, I'm trying to get by these slides to be very transparent because I have bullet points that you'll be able to understand better in just a second, so bear with me if you would. But I do want to point out down here that our old friend Southern diet in women explains 30% of the black-white differences in the development of hypertension. 50% in men, 30% in women, far greater than any other thing. The second biggest thing in women is BMI. So BMI is not important in men. For both white men and black men, it predicts the development of hypertension. But black men and white men have about the same BMI, so it doesn't explain the disparity in hypertension. In both white women and black women, BMI is related to the development of hypertension. But black women have, on average, much larger BMI than their white counterparts, and so that's playing a major role. So I'm going to go ahead and fast forward through this and hit these discussion points, which is really what you were just seeing on the previous slides. In both men and women, Southern Diet Score appears to be the most powerful mediator, the thing that is most important, excess risk of hypertension, explaining 51% of the black-white difference in hypertension in men and 30% in women. The sodium-potassium ratio was also a significant mediator in both men and women, and low DASH diet score was also a significant mediator in women. Collectively, this really suggests that diet appears to be a golden target for interventions to reduce the disparities in hypertension, a very important pathway for potentially making a huge difference. Also, a low level of education and neighborhood quality were the only other factors that explain black-white differences in both men and women. Waist and BMI was very important in women, but not in men. So strongly associated in both men and women. Black women had a higher BMI than their white counterparts. Importantly, one of the interesting things that came out of this research is there are other factors that are important in women but not men, and they included lower mobility, moving about, alcohol, income, physical activity, and education. So overall, in conclusion of this entire talk, what would I like you to take home? What messages would I like you to remember? The first thing I'd like you to remember is about half the black excess risk of stroke is attributable to the traditional risk factors. About half the black-white difference is attributable to the traditional risk factors. To make changes, we have to stop African Americans from developing a worse risk factor profile. Really focus on prevention of risk factors rather than control of the risk factors. By the way, I'm not saying that control is not important. Of course it is. But to reduce the disparity, we need to focus on prevention of the risk factors in the first place, primordial prevention. Promising targets to make a difference are particularly diet. The other half of the black-white differences is due to a number of other things. Differential susceptibility to hypertension is almost certainly playing a role. Novel risk factors, particularly diet, might be playing a role. And now we're just beginning to understand why African Americans are at higher risk than their white counterparts. Once we understand why, then we can begin to make changes to reduce that disparity. In final conclusions, it's my honor to be speaking to you. I'm honored to be here. I'm part of a large research team, and the credit needs to be shared with that entire research team. These are the people who are part of the study that I'm part of, and they include a neurologist in Cincinnati and neurocognitive scientist in Indiana and a central lab in Vermont. The way that we move forward now is team science. It's not the Renaissance man is gone. What it's about now is working as part of powerful teams, and these are our team members. This picture shows the investigators and then the staff of our study at UAB, and without the other investigators and the staff, the topics I've been discussing now would just simply not be possible. And then finally, on behalf of the study, the REGARD study, the Reasons for Racial and Geographic Differences in Stroke, much of what you've been hearing about is a product of this study, which was designed specifically to address this question of what it is about African Americans that leads them to be at higher stroke risk. And this is, I'm honored to be part of this study. Particularly appreciative of funding from NIH, specifically NINDS, the National Institute for Neurological Disorders and Stroke, who have been supporting this study for 15 years now, trying to help us understand what it is that leads African Americans to be at higher stroke risk.
Thanks, Dr. Howard, for talking about contributors to the African American Caucasian disparity in strokes. Our final presenter is Dr. Nadia Richardson, Director of Multicultural Initiatives at the American Heart Association. Dr. Richardson?
Thank you for joining us today. My name is Dr. Nadia Richardson. I serve as Director of Multicultural Initiatives with the American Heart Association. Our objectives for today's workshop are to describe the impact of uncontrolled blood pressure from a public health perspective as well as a patient perspective. There are two programmatic interventions that are signature to American Heart Association that we'll also be sharing in this presentation. One program is the Target BP initiative, and through this initiative, we collaborate with clinics to identify their hypertensive patients and help support the clinic in getting those patients under control. We'll review the registration and recognition process for the Target Blood Pressure program. We'll also identify evidence-based best practices as well as the research that informs the American Heart Association programs. Finally, we'll review the Check Change Control Initiative, which provides patients with evidence-based strategies for self-monitoring. The American Heart Association has a mission of building healthier lives free of cardiovascular diseases and strokes. We have a 2020 impact goal to improve the cardiovascular health of all Americans by 20% while reducing deaths from cardiovascular diseases and strokes by 20%. Millions of Americans live with high blood pressure. There are disparities based on race and ethnicity. Based on the numbers provided, 1 in 3 in regards to white populations, 2 in 5 Black, 1 in 4 Latino, and 1 in 5 Asian. However, with the new blood pressure guidelines identifying normal blood pressure as 120/80, these numbers will ultimately go up. There are a number of reasons why controlling blood pressure is important. Morbidity and mortality due to cardiovascular diseases is directly linked to high blood pressure. Also, when blood pressure is lowered in patients who have been diagnosed as hypertensive or identified as living with elevated blood pressure, less vascular damage is done to organs, specifically the eyes, brains, heart, and kidneys. We have known since the 60s through the landmark VA1 and VA2 trials that treating high blood pressure with medication reduces risk from heart attack, strokes, and death. This is over a 20-year study that started in 1964 and ended in the 1980s that really provides information and evidence that medication adherence reduces the risk of heart attacks and strokes. Barriers to success in blood pressure control include patient factors, systems factors, and physician factors. Patient factors include social determinants of health, absence of symptoms, and non-adherence to drug treatment. Systems barriers include lack of useful data and performance metrics. Physician factors include limited time, competing factors, and failure to recommend follow-up. Based on research, the American Heart Association has developed 2 blood pressure programs that take 2 separate approaches to helping identify hypertensive patients and support them in getting their blood pressure under control. One program has a clinical focus, the Target Blood Pressure program. The other program has more of a community focus, the Check Change Control program. The Target Blood Pressure program is a call to action motivating medical clinics to prioritize blood pressure control. The American Heart Association supports clinics through education, material, and resources provided to patients who have been identified as hypertensive. Through the program, clinics also receive recognition for attaining high levels of blood pressure control in their patients' populations. The American Heart Association supports clinics through the Target Blood Pressure program by providing tools and resources to their patients, as well as training their clinic staff on how to properly take blood pressure utilizing an algorithm that was developed through a scientific advisory. The Target Blood Pressure program was developed through a partnership with the American Heart Association and the American Medical Association. It is also based off of the MAP framework that focuses on measuring accurately, acting rapidly, and partnering with patients in order to get blood pressure under control. Through the Target Blood Pressure program, the American Heart Association helps organizations create a plan for improving blood pressure control. Our target audience for administering the Target Blood Pressure program include primary care systems. At this time, because of our focus on social determinants of health, we've been doing a great level of work through federally qualified health clinics due to the fact that their patient populations are typically underserved, underrepresented, and socioeconomically disadvantaged. Many of those patient populations include individuals who are also on Medicare, Medicaid, or underinsured. The Target Blood Pressure Program is also available through government agencies or organizations that provide care to patients. While we know that drug adherence is incredibly important to getting blood pressure under control, we also know that peer support methods and patient navigation helps to support patients in taking ownership of their blood pressure control. The American Heart Association has taken all of those things in consideration in the development of the Target Blood Pressure Program. In addition, we've provided another layer of evidence-based research in the development of an algorithm through a scientific advisory. Combining those things, we have developed a Target Blood Pressure Program that has proven to be an evidence-based initiative and intervention for helping to get patients who have been identified as hypertensive by the clinics that partner with us under control. We know that clinics are doing everything possible to get their patients under control, but we also know that there are limited resources and limited time in being able to support those patients on a one-on-one basis. We also know that clinics are required to report specific performance metrics. The American Heart Association can support not only getting those patients under control, but also support clinics in helping to structure their reports in a manner that is going to be beneficial to them based on the performance metrics that are already required to report. Ultimately, this leads to improved health care and for their patients, but also improved practices for the clinics themselves. Uncertainty of a patient's true blood pressure is the leading cause for failure of a clinician to act on a high blood pressure reading in the office. One of the reasons that this may be is that high blood pressure is often known as a silent killer and can often come with no symptoms at all. So if a patient is coming in for a regular checkups, they may not be able to communicate that they are experiencing any particular symptoms because they may not be experiencing those symptoms. For patients that also do not come in on a regular basis to get their blood pressure checked, there may be significant differences in the blood pressure readings of patients in their records. Poor measurement techniques also decrease reliability of a patient's blood pressure reading and can lead to poor clinical decisions. So how does this impact clinicians in practice? Blood pressure variabilities exist in everyone and contributes to uncertainty, and the uncertainty about the reliability of blood pressure is one of the leading reasons clinicians fail to initiate or escalate therapy. Routine conventional office blood pressure measurements correlate poorly with daytime blood pressure readings. Poorly performed blood pressure measurements result in inaccurate blood pressure readings. This is another reason why the algorithm that we will discuss shortly is so important. While self-monitoring is a proven and effective way for hypertensive patients to gain control over their blood pressure, most hypertensive patients still only have their blood pressure checked when they come into conventional office settings. There are a number of reasons why patients may only come into a clinic to get their blood pressure checked. Some of those reasonings focus on social determinants of health. Do they have access to a clinic? Do they have time to take off of work? Do they have reliable, ongoing, regular access to transportation that can get them to a clinic on a regular basis to have their blood pressure checked and monitored effectively? Until patients can be supported in monitoring their blood pressure at home, the best way for us to reduce some of the challenges of uncertainty in patient blood pressure is to reduce the common measurement errors that do take place during conventional clinical visits. It's also important to standardize the process of measuring blood pressure. This is all done through the algorithm that's shared through the Target Blood Pressure Program. The American Heart Association, the American College of Cardiology, and the Center for Disease Control and Prevention developed a scientific statement in 2013 that outlined an algorithm on how to properly take blood pressure program. This provides standards that eliminate some of the errors that do take place on a regular basis in clinics when patients' blood pressures are being taken. While the scientific advisory came out in 2013, in 2015, the American Heart Association began a focused drive to promote the use of the algorithm in healthcare systems and clinics. This is a signature component of the Target Blood Pressure Program. Based on the highlights of that scientific advisory, infographics were developed outlining simple tips on how to get an accurate blood pressure reading. Clinics that are a part of the Target Blood Pressure Program are provided not only with the scientific advisory and additional training on how to properly take an accurate blood pressure reading, they're also provided with posters and material that they can present to their patients so that patients can take ownership in making sure that they are also following these guidelines. Also, posters such as this one are provided to clinics and hung throughout their exam rooms. This is not an uncommon scene in regards to a patient's interaction in getting their blood pressure checked in a clinic. However, just taking a very quick look at this picture, how many errors in blood pressure measurement do you see? The algorithm that's used through the scientific advisory as a part of the Target Blood Pressure Program outlines simple tips on how to get an accurate blood pressure reading. Based off of that picture, these simple things are actually increasing that patient's blood pressure reading. Her back is not supported, her arm is not supported near heart level, the cuff is over her sweatshirt, her legs are crossed, her legs are not both flat on the stool, she is talking and she is listening. And we still don't know whether or not she had had the opportunity to maybe go to the restroom before her reading, sit for a moment and catch her breath before the reading, or whether the cuff size is the appropriate size for her. Talking is one of the signals a lot of times that we see in clinics that we have the opportunity to engage. It's just regular pleasantries that the nurse might be asking of the patient, but in fact the patient shouldn't be talking at all, not on the phone, but also not to the individual who is taking their blood pressure. These common measurement errors can have a significant impact on the blood pressure reading. So imagine, just based off of this graph, if only 2 or 3 of those errors are present, it can make a significant change in the blood pressure reading of the patient. Cuff size is actually an opportunity not just for the clinic to properly take blood pressure, but also for the patient to take ownership of a blood pressure. There are various sizes that are available, and they can be adjusted accordingly. However, if a patient is fully aware of the fact that they need a particular size, and they can take that information and actually ask their clinician as they're having their blood pressure checked, is this the appropriate size for me? Or I typically use this size. Based on research, the bladder length is about 80 to 100% circumference of the arm, and then width is at least 40% circumference from the arm. So these are also things that are outlined in the algorithm and things that are should be taken into consideration by the clinician. But also, it's an opportunity for the clinician to communicate that to the patient, so the patient has that information for themselves going forward. While the scientific advisory that outlines the algorithm is provided to clinic staff who sign on to Target Blood Pressure, it also provides information on patient factors that can be communicated to the patients by the clinic staff. So we provide handouts and materials, flyers, brochures that outline some of this information that can be provided to the patients so that they can take that information home for themselves. Because patient factors such as stimulants, whether or not they had recently eaten a meal before coming in, whether or not they have been talking, texting, whether they had recently exercised, or whether or not they may have a full bladder, are things that they can take ownership of, but only if they're truly mindful of it. So while this information and this training is provided to the clinics as a part of the blood pressure program, the Target Blood Pressure Program, it's also an opportunity to provide that material to patients so they can be mindful of that information going forward. So keeping all of these common errors in mind is all a part of the MAP framework, which is a part of the Target Blood Pressure Program as well. So measuring blood pressure accurately, all of that information in regard to the common errors that are made in monitoring and taking blood pressure in a clinic falls under that. Acting rapidly to manage uncontrolled hypertension, so having the clinic make their immediate interventions and engage the patient on a treatment plan in order to get their hypertensive readings under control, and partnering with patients and families and communities. A lot of times, in regards to patients' adherence, not just to drugs and medication, but also to treatment in regards to exercise, in regards to their food intake, in regards to the types of foods that they're eating, a lot of that is not going to be, they're not going to listen to it if that relationship is not developed with the patient and doctor. So really encouraging the patient to take ownership by being mindful of how this information is communicated to the patient, building rapport with the patient, and really putting the ball in the patient's court in regards to these are the medical interventions that we can provide, but these are also the behavioral interventions that you can take ownership of and do for yourself, and we can support you in these efforts. The Target Blood Pressure Program kind of falls in the middle of all of that by supporting the clinic as well as supporting the patients. Ongoing resources are available for patients as well as clinic staff, whether it's through webinars, podcasts, or videos, fun fact sheets, supportive material, brochures, and also other resources, whether they might be trainings. One of the things I enjoy most about the Target Blood Pressure Program is that it can be tailored to the needs of the clinic and the community that that clinic serves. So, for example, we are working with a clinic right now in Birmingham, Alabama, who their patient population is an older, aging population. When we met with them and they signed on for Target Blood Pressure Program, we talked with some of the nurse directors about how we can get their patients involved in the program, how we could train their staff, what they felt like the greatest needs were. And part of it was that they needed more education, and that their patients needed to be more involved in physical exercise. But as an older population, what did that physical exercise look like? Well, as American Heart Association, we identified that there was a YMCA right up the street from that clinic. So we regularly partner with YMCAs. We went to them and talked to them a little bit about the needs of that particular clinic that's right down the street from them, and partnered with them to develop what is now called a Stronger Together program out of that clinic. And through that clinic, now patients are provided with blood pressure monitoring, self-monitoring blood pressure monitors that they can take home. They also have access to the Y for 4 months for free. And as a part of that, they are going to learn certain exercise techniques that are applicable to their physical ability and age range and just interest as well. And then we are also, as the American Heart Association, doing monthly workshops on diet and exercise and blood pressure readings and medication adherence. And so it's tailor-made for that particular clinic. Similar things are being done in other clinics throughout the state of Alabama. Another aspect of the Target Blood Pressure Program is that we've also been fortunate enough to be able to secure certain levels of grant funding. So if there's a clinic that has signed on for Target Blood Pressure Program, specifically maybe an FQHC that is serving an underserved and challenged community, we've been able to partner with them, secure grant funding, and then provide those clinics with monitors that the patients can take home, as well as patient navigation. So that just adds another level of support. So again, signing on to the blood pressure program, you do get a great level of support just for being a part of the program, but you also have the opportunity to tailor the program in a way that's going to be most beneficial to your clinic and your community. So how can you help? You can become a part of the Target Blood Pressure Program. You can visit our website at targetbp.org and register from there. You can review the resources and information on the website and share this information with your colleagues as well as other clinics in your community. The Target Blood Pressure Program is more of a clinical approach in how to support hypertensive patients in getting their blood pressure under control. The Check, Change, Control program is specifically a program developed on how to provide patients with strategies for effectively self-monitoring their blood pressure at home. There are a number of reasons why patients do not monitor their blood pressure at home. One of them could be financial. Blood pressure monitors can be a little pricey. However, being a part of the Check, Change, Control program does not require that you have a monitor at home. We can assist in helping you identify what monitors may be available in your communities. And as many of us know, monitors are now available in a lot of stores or pharmacies, whether it's a CVS or a Walgreens, sometimes even in a Walmart and a Publix, you'll find a blood pressure reading machine. So barriers to success, that's one of them, but we're also able to work with individuals who are interested in participating in our Check, Change, Control program to help them identify other ways that they can participate in the program. Non-adherence, again, financial ability to be able to secure a monitor, but also literacy and understanding what it means to monitor your blood pressure at home, monitoring it on a regular, ongoing time, how many times a day, before or after medication. These are all kind of health literacy questions that can be answered, but often patients don't know where to get that information, and so they just don't monitor. Physician factors oftentimes include just time to communicate and educate the patient on what it means to properly self-monitor. Systems factors to self-monitoring often include leadership and buy-in, because again, it takes a certain amount of time for a physician to put into educating a patient on what it means to self-monitor. So what is self-measured blood pressure monitoring? It is the use of a personal blood pressure monitor for the diagnosis and management of hypertension. Patients are typically trained to use a blood pressure monitor in familiar settings, usually in their homes. However, this can also be done in clinics. For example, as I mentioned before, the target blood pressure program that we have been working with a clinic, and we've been able to offer some of their patients blood pressure monitors. Training on how to properly use that monitor has been provided in partnership with the American Heart Association in workshops at those clinics. Self-monitoring has proven to be effective because it occurs in the patient's usual environment. It's at their home, so it eliminates the white coat syndrome. It provides multiple readings over a period of time as well, so you can get a better idea of what a patient's blood pressure looks like over a length of time and not just during sporadic clinical visits. Self-monitoring can help correctly diagnose patients at risk of hypertension by confirming elevated office readings and differentiating between white coat syndrome and sustained hypertension. Some of the pros and cons of self-measurement include pros: it's convenient, it lowers blood pressure if used effectively, it rules out the white coat syndrome, and helps patients whose hypertension may be masked, who maybe experience hypertension with no symptoms. Some of the cons, again, is that patients may consider it cost prohibitive if they feel as though they are not able to afford a blood pressure monitor. However, we remedy that, again, by identifying monitors that might be in their community that they can tap into, but also for certain clinics who are able to collaborate with the American Heart Association, exploring other options and ways that we might be able to help them secure blood pressure monitors for their patients, whether it's through collaborations with other organizations or through grant funding. As all American Heart Association programs, the Check Change Control program is evidence-based. It utilizes a tracker, an online tracker that empowers patients to take ownership of their cardiovascular health. They're able to track their numbers through the online tracker, tap into resources, get certain strategies and techniques on how to incorporate physical activity and healthy diet into their blood pressure management and treatment plan. It also assists them in weight reduction and other forms of high blood pressure management. While the program itself is set up to be a 4-month education program, once patients are signed on to the Check Change Control program, they are allowed and able to access their online tracker and participate in all the resources and information indefinitely. The Check Change Control program encourages patients to take weekly readings, or at least 8 readings a month over the course of 4 months. The target audience are individuals living with high blood pressure. However, anyone can sign on to be a part of the Check Change Control program. Sometimes these programs are done through corporations and schools, churches, but clinics are also encouraged to participate in the Check Change Control program. For example, it is not uncommon for clinics that have signed on to our target blood pressure program to also sign on for the Check Change Control program, just as another layer of support, especially since the target blood pressure program is specifically for patients who have been identified as hypertensive. There are some patients who are not quite hypertensive, but can also tap in and utilize and benefit from participation in self-monitoring. And so the Check Change Control program ends up being a very useful program to them, as well as those who have been identified as hypertensive. The Check, Change, Control program was piloted initially as the Check It, Change It program. The target population at that time was African Americans. And it proved to be an effective community-based intervention for controlling blood pressure in the African American population. However, the Check, Change, Control program is now available to all individuals through different organizations, again, through churches, through companies, and again, it does prove to be another effective layer of support to clinics. Check, Change, Control engages adult populations by encouraging them to check their high blood pressure and symptoms, change their lifestyle, and seek treatment, and control hypertension by taking preventative measures. So it really is just another added layer of support to patients, but also encourages them and empowers them to take ownership of their overall treatment plan by being able to self-monitor, have these numbers, be aware of these numbers, be aware of these symptoms, buy into the strategies that will help them get their blood pressure under control, but also use all of that information to work in partnership with a physician. Again, the Check, Change, Control life cycle is identified as 4 parts. The first part being that individuals were recruited from the community to participate. They enroll online and start adding their information and monitoring their blood pressures through the online tracker. They participate and tap into the site resources and information and some of the workshops and some of the information that's provided and available to them on the site. And they continue to track and monitor all of their numbers over the course of 4 months and are able to assess the progress that they make. Again, while this is a 4-month educational session program and it's set up to be that, once patients are registered, they will remain registered until they themselves go online and decide to not be registered anymore. When the Check It, Change It program was piloted, before it became the Check, Change, Control program, research was published that proved that tracking blood pressure on a regular basis, monitoring readings at home and outside of a clinical setting was an effective way of maintaining and monitoring blood pressure, but also empowering patients to get their blood pressure under control. It additionally provided evidence that the use of a digital self-monitoring communication tool proved to be beneficial to patients that did not regularly go into their clinics. Hypertension is an identified health disparity in the African American community. Because of that, the piloted program, the Check It, Change It program, was focused on the African American population. So that is just a multicultural programmatic approach to making a difference in hypertension in a targeted population. It showed that coaches and encouragement of participants proved to be an effective way of helping patients to take ownership and even learn about what it means to have their blood pressure under control. It also showed that charting and tracking their self-management skills related to blood pressure management actually helped to maintain blood pressure levels. So how can you help? You can become a part of the Check, Change, Control family by visiting our website, www.heart.org/ccc. Here you'll find information and resources about the Check, Change, Control program, as well as how you can share it with your patients and how you can sign on as a clinic. You can also become a Check, Change, Control champion and lead a program through your clinic. Again, this is something that clinics regularly do if they've already signed on to our target blood pressure program. It's very common for clinics to have the target blood pressure program and the Check, Change, Control program go hand in hand. Thank you so much for your time. We at the American Heart Association are dedicated to improving the lives of individuals, and we look forward to partnering with you as you learn more about our target blood pressure program and our Check, Change, Control program. Feel free to contact me with any questions that you may have.
Thank you, Nadia. If you have any questions, please call or email us now. I'll start us off with the first question. Joining us today, we have Dr. Deborah Hodges, Senior Research Analyst here at the Department of Public Health. Dr. Hodges, could you just reiterate a little about what we just learned about hypertension in our state, as well as what can we expect with the release of these updated blood pressure guidelines?
Certainly. One of the main take-homes is that our prevalence of high blood pressure in Alabama is about 10% higher than the nation as a whole. However, we do have to be cautious in using these data, as there are no real hard and fast data out there. These are estimates based on the Behavior Risk Surveillance Survey, and it's generally called BRFIS. And BRFIS is a telephone survey with self-report from thousands of citizens throughout the U.S. Alabama has been participating in it for, I believe, about 25 years. So it's very well known, and that's often what you see when you go to websites and so on. And it is based on self-report. Now, there's two problems with that. In taking a telephone survey usually during the daytime hours, there may likely be a bias in who's at home to answer the questions. It may be heavily laden with retired people and with stay-at-home moms, both of whom are just thrilled to death to talk to an adult voice on the phone. And so that kind of stretches the credibility of that type of data a little bit. The other big factor is that this is self-reported data. And frankly, I'm not going to tell my real weight if you ask me on the phone or otherwise. So there's always some bias in there, not only about not revealing actual facts, but also wanting to please the surveyor to keep them talking with you. So we do have to take these numbers with a grain of salt. Now, it is likely from the studies we've done in our cardiovascular health unit that those rates could be much higher. I have been working with patients in the Mobile County Health Department for about 4 years now, and looking at their blood pressure data in their EHR system. And I can tell you that their rates actually are higher than what this is reported as. In this patient population, these are all patients that are diagnosed with either hypertension or diabetes, and most frequently both. And out of that patient population of about almost 12,000 patients, more than 7,775 roughly are uncontrolled. Their blood pressure is totally uncontrolled. Now, the new standards, which have a lower threshold, when we start going fully to those new standards, that's going to add an additional 2,100 to 2,500 patients to the uncontrolled section, which means it'll increase by 1/3 roughly. So we're going to see a lot of major changes coming up, and we do have a lot of programs that we're trying to work towards helping solve some of the problems that you saw so graphically in some of our presentations. All the presentations were really good. I'm very impressed with them.
Well, thank you, Dr. Hodges, and thank you for sharing that information with us. We also have Bill Kennedy here in the studio with us. Bill is the social work director here at the Department of Public Health. And Bill, I was hoping you could tell us a little bit why we're flashing on the screen about men's health.
Well, the biggest thing that I wanted to point out is that heart disease continues to be the #1 cause of death for men in Alabama. And strokes are number 5 on that list. And I think the biggest thing that we could do is just to encourage men to have preventative care, to see their primary care physician. Certainly some of the things that have already been talked about today, eating right, exercising, following up with their physician, those are all important as well.
Also, would you like to share anything about the role that social workers can play in helping providers with helping their patients to manage their high blood pressure?
Social workers do a lot of different things throughout the state and for a lot of different in settings, but one of those things is, education, providing resources and encouraging men to and women to follow up with their primary care physician, to seek out resources if they're having problems with medications, finding resources to help pay for medications, or even the cuff we were talking about earlier, the blood pressure cuff, finding resources that can help them get the results that they need. And there are a lot of other places that you can check your blood pressure, whether it's at a local CVS or Walmart or whatnot. A lot of those places have machines there where you can check your blood pressure and just managing your blood pressure on a regular basis.
Thank you, Bill. And that concludes our session for today. Thank you so much for joining us. We hope you enjoy the rest of your day.